Hi and welcome to the channel Love Obstetrics and Gynaecology. Today I'll be discussing face presentation. So in case of a normal labor, we have a longitudinal lie, Catholic presentation and a well flexed head, which means that the presenting part will be vertex. Whereas in face presentation, we have complete extension on the head, which leads to face being the presenting part. So in this video you will learn what is face presentation, how is the mechanism of labor different in face presentation, the diagnosis and its management. So first, defining the face presentation. See, the face presentation basically means that this part of the fetus will be will be the presenting part and overlying the internal os. So talking about this part, it is bounded above by the glabella or the root of the nose and the supraorbital ridges, and below by the junction of the floor of the mouth to the neck. So this part will be our presenting part. So in a normal labor or in the normal presentations, we have the longitudinal lie, which means that the fetal spine is parallel to the maternal spine or the centralized uterine axis, and we have the head of the fetus in the lower part of the uterus. That means cephalic or cephalic is our presenting part. And in case it is a normal where we have a complete flexed attitude of the baby, we have the vertex as the part that overlies the internal os. But in case of a face presentation, there is extension at the level of fetal neck. So this head is now, the occiput you can say, is in contact with the back of the baby. It is so extended that it is in contact with the back of the baby, and the face becomes the presenting part or the part that lies over the internal os, like this. Next we have the positions. There are 4 positions of the face according to where the denominator lies. See, in the face presentation we have chin as the denominator or the leading point, and in relation to where is the chin present, we say there are 4 positions of face presentation. So chin can be anterior, in the interior aspect of the pelvis, or in the posterior aspect of the pelvis, and accordingly we have left mento anterior, as this chin is in contact with the iliopubic eminence on the left side. Or we can have right mento anterior, then we can have right mento posterior, as the chin goes back and now is in contact with the right sacroiliac joint. Next we can have left mento posterior, and the most common position that we have is left mento anterior. Now let me explain you how. See, basically we have first as the primary position or the secondary position. The primary position means that the position was already there before the patient went into the labor. So the patient during the pregnancy had a position, and even in the labor she continued with the same position. And secondary position means that the position changed as the labor had its onset. So the position that dwells secondary after the onset of labor, we call it as secondary position. So this is the secondary position. The face presentation is most commonly a secondary position, which basically means that during the pregnancy, the patient was having a normal cephalic position with the vertex as the presenting part. Maybe the occiput was in the posterior segment of the pelvis, and as the right occipital position is more common than the left occipital position, because on the left side we have the sigmoid colon and the rectum. So the right occipital position was more common, and there were some unfavorable circumstances that did not promote flexion but instead led to extension. So that extension leads to development of a face presentation. And now see this right occiput on the right sacroiliac joint, this was the primary position, and as the patient underwent labor, there was onset of labor pains, the position changed, and now the secondary position that developed was a face presentation, and this chin now comes in contact with the left iliopubic eminence. So we have a left mento anterior position, and this is the most common position. Talking about its incidence, the incidence of face presentation as such is you can say around 1 in 500 births. So what factors favor a face presentation? See, there are various maternal and fetal factors that favor a face presentation. A face presentation, talking about the fetal factors, first in the fetal factors we have a congenital malformation of the fetus, that is the anencephaly fetus, or the extensor muscles, they are more in the spasm, they favor a extension on the fetal head. Or you can have some neck tumor that causes extension on the fetal head. Or we can have some maternal factors such as the pelvis might not be adequate, or a specific pelvis, that is the flat pelvis, favors more for the face presentation. Or the multiparity. The multiparity as such favors many malpresentations and malpositions, and face presentation is one of them. Now let's discuss the mechanism of labor. First thing first, so the mechanism of labor or a vaginal delivery can occur only in the anterior positions and not in the posterior positions, and I'll tell you why later on. So first let's discuss the anterior positions. We can either have a left mento anterior position or a right mento anterior position. And now let's discuss the engaging diameters. The engaging diameters on the fetal head, the transverse diameter will be the biparietal diameter between the two parietal eminences, which is 9.5 centimeter, and the submentobregmatic diameter in a completely extended head, so that we have a face presentation which is also 9.5 centimeter. Now just to tell you what is the difference between the normal labor and the face presentation. So in a normal labor you have the engaging diameters, that is the biparietal and the suboccipitobrachmatic, and both of them are also 9.5 centimeter. But see, they are in so much close proximity to each other. This is our biparietal, this is our suboccipitobrachmatic diameter, and they form a almost circular disc. Whereas in a completely extended face presentation, we have this as our submentobregmatic diameter and the biparietal diameter, and there is a lot of difference between these two diameters, and approximately you can say the 7 centimeter difference. So the first movement that occurs in the mechanism of labor is engagement. So a lot bigger part has to get engaged. A lot of there is a long process or a long distance between these two diameters to engage, so the engagement is delayed. So first is engagement is delayed, and I'll be telling you the mechanism as per the left mento anterior, as it is the most common position. So my left mento anterior, the chin being the denominator, it is in contact with the iliopubic eminence on the left aspect, and first thing is our engagement, so the engagement occurs delayed. The next thing is the descent. The descent occurs and the chin touches the pelvic floor, and as it touches the pelvic floor, the chin will rotate towards the symphysis pubis, and the extension will get promoted. In the normal labor, again explaining you what is the difference between the normal. In the normal labor, the flexion gets promoted on the fetal head, whereas in face, extension gets promoted as the fetus or the face chin touches the pelvic floor. Then finally it rotates and it moves behind the symphysis pubis anteriorly. Now our shoulders in a left mento-anterior are firstly in the left oblique diameter. They do not change their position, they remain the same in the left oblique position. Only the chin rotates by 1/8 of the circle, and now chin is behind the symphysis pubis. Furthermore, descent occurs, and finally the diameter that stretches the vulval outlet is your submento vertical diameter. So more of the engagement, more of the descent occurred, and now the baby has to finally deliver, so it is more deep down in the pelvis. The submento here behind, over here, submento between the junction of floor of the mouth to the chin, submento to vertical, that diameter is approximately 11.5 centimeter, and this diameter stretches the vulval outlet. And finally the head is delivered by flexion. The head is delivered by flexion. So the first thing that gets released is your chin, then face, then brow, then occiput, and then vertex. So head delivers by flexion, whereas in case of a normal labor it delivers by extension. The next thing is the same as per your normal labor. So we had our shoulders in the left oblique, they engage as such. There will be a restitution on the fetal head as it delivers to 1/8 of the circle in a rotation opposite to that of internal rotation. So if in the left mento anterior the chin became anterior, outside the mother's outside the vagina it is going to again rotate backwards, and now to 1/8 of the circle, right? And now the shoulders are in the oblique diameter, they have to get engaged and deliver, so they finally rotate by 1/8 of the circle, or that is evident as basically our external rotation. So then finally the chin faces towards the maternal left thigh, and finally again the anterior shoulder and the posterior shoulder deliver, and rest of the body by lateral flexion, same as in the case of a normal labor mechanism. Now a quick word regarding why the posterior positions do not deliver. So in case of a posterior position like this, whether it is left mento posterior or the right mento posterior, this baby cannot rotate that well. See, the abdomen can accumulate a lot of things, but this behind the sacrum and the spine, they cannot accommodate that such a big baby. And a bigger diameter that comes in play is our sternobregmatic diameter. So from the baby's sternum to the bregma, this diameter is your engaging diameter, right at the level of sacral promontory. Your sternum is present, and anteriorly your bregma is in contact with the pelvic brim. So this is a very big diameter, you can say 7 inches or around 18 centimeter diameter, and nowhere in the pelvis we have a diameter where a 18 centimeter diameter can be accommodated. So there is no mechanism in the posterior aspect or in the posterior positions of the face presentation. Now let's talk about how do we diagnose this condition. See, I'll tell you grip by grip. So in the first grip, here we have on the first grip the fundal grip. We can feel for a soft, broad, irregular, non-ballotable structure which will be the buttocks. The next, our second grip, on our second grip or the lateral grip, we will be able to see or we will be able to feel for, actually, there will be back on one side and the limbs on the other side. So here first I am telling you about a mento posterior position. So in this mento posterior position, you can see that there is the body of the baby, and then this body of the back of the baby is directly in contact with the occiput. So in the lateral grips, yes, you will be able to feel the back on one side and the limbs on the other side. And now coming on to our third grip, or both the pelvic grips, the inference of the third or the fourth grip. What will be that? You will be able to appreciate a groove present between the back and the head of the fetus. The head will seem to be very big in size, and that head will not be engaged. The engagement is usually delayed, and as such in the posterior position the engagement is very difficult. As I told you, a very big diameter is in play, so there will be a very big head that will be non-engaged. And the fetal heart in a posterior position, it is not very easy to locate the fetal heart, and it will not be that much audible, and it may be audible to one of the flank regions. So in this case we have a left mento-posterior position, so somewhere over the right flank region you might be able to auscultate the fetal heart. Next, coming on to the left mento anterior position. So in the left mento anterior position, so again on the fundal grip, first grip, a soft, broad, irregular, non-palatable structure. On the second grip we can feel for the back, which is not very appreciable, but the limbs will be more appreciable. And next thing is, there will be a bigger head that will not be engaged, or that may be engaged. In case of anterior position it can get engaged, but usually it will not be engaged, and it will be a very big size. And the groove will not be as such more prominent. So in a posterior position it was more prominent, but in the anterior position it is not that prominent. And the fetal heart, you will be able to auscultate for the fetal heart through the chest of the baby. Usually we hear the fetal heart from the back of the baby. So here we will be able to auscultate for the fetal heart right from the chest of the baby. So this was about the per abdomen examination, and now I'll discuss about the per vaginum findings. So the per vaginum findings, the presenting part is our face. This is our presenting part. So as this face gets engaged, you will be able to appreciate this face through the vagina. So here I am going to tell you what are exactly the findings of a per vaginum examination. So we have the left mento anterior position, and we do a examination to assess for the fetal parts. And you have to be very gentle, because you do not want to injure the eye of the baby or any other part. Now the face is a soft part. The face is a soft part which is comparable to the buttocks of the baby. So if you have a head, this is a very hard part, but the face is a very soft part. So talking about this face, we have to assess a few things. We have to feel for the mouth, the alveolar margins inside the mouth, the nose, the malar eminences, and then you can feel for the supraorbital ridges. So first thing is, if you find a opening on the part which is presenting, and you gently insert your finger inside it, and then you feel around it, what can you feel? If you feel any hard alveolar margins, that means it is a mouth. And then you finally take out your finger from that, and then you try to feel for the malar eminences or any bony projection that is present on that soft part, that which is our malar eminence. The malar eminences on each side and the mouth in between them are they make a triangle. These 3 points make a triangle. Whereas if we consider the buttocks, there is an anal opening. The anal opening, if you put your finger inside it, there will be no hard alveolar margins, and then you feel for outside on that outer aspect of that presenting part, you feel for the any bony prominence. There will be two trochanteric eminence, which the two trochanters, the anal opening, they will be in a line to each other, whereas in the face presentation they are they make a triangle. And then you can also feel for the supraorbital ridges. Next, when you remove your finger, examine your gloved finger whether there is any meconium staining or not. The meconium staining will be present if you have gone through an anal opening and not in case of mouth. So finally, managing the face presentation after you have adequately assessed the patient. So you have checked for the pelvic adequacy. You know the size of the baby, that there is no relative cephalopelvic disproportion between that, and there is no complicating factors. And complicating factors can be any, like such as the patient can have preeclampsia or any other complication of the pregnancy, or you have also ruled out that there is no congenital malformation in the baby that may hinder the delivery of the baby. So if you have assessed everything and the position of the mentum is anterior, then we can go for the vaginal delivery of the baby. But we have to be very cautious, as you know that there is going to be a delay at every step. First there will be delay in engagement, then throughout the process of the head that has to pass through the pelvis, as there will be more and more of the extension of the fetal head, and the fetal facial bones, they are not as much as molding, they do not prefer much of the molding in comparison to the skull bones. You know, there will be delays at every step of descent. Next, also you have to be prepared, as it does not form a adequate disc or a ball valve structure as the contraction comes. So the membranes are more likely to rupture and there can be incidence of a cord prolapse. So you need to be throughout the process of first stage of labor or the second stage of labor, you have to be very much cautious. Especially these were the points in the first stage of labor. Now coming on to the second stage of labor, when you are finally delivering the baby. So when you are delivering that baby, you need to give a liberal episiotomy, because the head is going to be borne by flexion. This, as the baby's head has to travel a bigger diameter is stretching the vulval outlet, and a lot of perineal trauma can occur as the baby's head is going to deliver. So you have to give a liberal episiotomy, and you have to give a very good perineal support so as to prevent the further any more perineal tears or the extension of the episiotomy that you have given. Also have a pediatrician on standby, as you want to prevent everything. You want to prevent the delays or any kind of intrapartum birth asphyxia, but these things can happen. So you need a pediatrician to adequately resuscitate the baby in case any of the mishaps occur. In case the pelvis is not adequate or the baby is very good size, or you have a posterior position, it is better to go for a cesarean section to have a good maternal and a fetal outcome. So this was all regarding the face presentation. If you like my video, please do like, subscribe and share the channel Love Obstetrics and Gynaecology. Thanks for watching.